Hi everyone, my name is Pritika. I am a pediatric neuroradiologist at Great Ormond Street Hospital, and today I'll be speaking to you a bit about acute stroke. So without further ado, we will speak about a bit about the incidence, etiology and differential diagnosis of childhood stroke. Also, I hope to provide you with some updates on the topic of diagnosis, management, and touch upon the role of intervention, hopefully towards the end of the lecture, and speak a bit about future directions. So what are the challenges of stroke diagnosis in children? When I was preparing for this talk, I found two very good review papers which essentially talk about the challenges in pediatric stroke. And there was one big study that really fed into these two review articles, a study by Raffet et al., which was actually performed in Toronto Sick Kids in 2009. And this study found that the median pre-hospital delay from symptom onset to presentation for stroke presentations in children was 1.7 hours. Now, the median in-hospital delay from presentation to diagnosis was 12.7 hours, which gives us a bit of an insight as to the causes of delay within pediatric stroke. Now, this is a bit closer to home for our institution, but this is a study or a cohort from UK 2015, a study performed by Institute of Child Health, which studied 96 children with acute ischemic stroke and 43 with hemorrhagic stroke. And again, what they found was the median time to onset from diagnostic imaging was 24.3 hours in acute ischemic stroke and 2.9 hours in hemorrhagic stroke. The initial imaging modality was CT in 68% of acute ischemic stroke, and this was only diagnostic in 66% of the cases. MRI then was performed, which was diagnostic in all of the cases. And if the initial neuroimaging was non-diagnostic in acute ischemic stroke, then the median time to diagnosis was 44 hours. What do we learn from these studies? That the diagnosis of acute ischemic stroke in children is delayed at every stage, from lack of recognition by the caregiver and initial ED doctors to also the point of their first neuroimaging. So moving on, just something that is quite important to remember, that whilst we may be used to approximately only 15% of adult strokes being hemorrhagic, actually half of the strokes that occur in children are hemorrhagic and the other half are ischemic. The causes of childhood stroke are also distinct from those in adults. The incidence ranges from about 3 to 13 children per 100,000 between the ages of 28 days to 18 years. And the causes of childhood stroke, so whilst, they do have arterial ischemic strokes, these will be non-atherosclerotic in etiology and include causes such as focal cerebral arteriopathy, which can be both of the inflammatory and dissection type. Also entities such as Moyamoya feature, as well as sickle cell disease. The other main causes of stroke are cerebral sinus venous thrombosis and also hemorrhagic stroke. Apart from your usual causes of infection, trauma and dehydration, the other main causes of CVST are cardiac or underlying hematological causes, also inheritable prothrombotic disorders. Within the realm of hemorrhagic stroke, in addition to acute infection, trauma and CVST predisposing to hemorrhage, we must also consider other underlying genetic and acquired hematological disorders, and also sporadic and genetic causes of vascular malformations. Other genetic conditions such as COL4A1 and COL4A2 should also be considered, as well as brain tumours and leukemia. So this is a really good pie chart which demonstrates the leading causes of childhood stroke, taken from a primer in one of the Nature articles called Childhood Stroke, and it essentially shows that intracranial arteriopathy is the largest risk factor for FCAD and FCAI, and also Moyamoya, vasculitis and genetic arteriopathy, that cardioembolic causes and arteriopathy are the leading causes of and the most frequent etiologies underlying and underpinning childhood stroke, and congenital or acquired heart disease affects a large proportion of children. Now, the International Pediatric Stroke Study, or the IPSS, defines childhood acute ischemic stroke as the follows. So, the presence of a neurological deficit of acute onset, presence of radiographic evidence of infarction conforming to a known arterial territory and corresponding clinical manifestations, and also that these symptoms should occur in children of 29 days to 18 years of age. This differs slightly from perinatal stroke, which occurs from 28 weeks of gestation to 28 postnatal days, and has a unique pathogenesis reflecting the maternal fetal unit, which we won't have time to go into in this talk. So without further ado, let's talk about our first case. So this is a 9-year-old who was presenting with episodes of transient right-sided weakness. Now, as you can see here, there are areas of chronic established ischemic damage within the left internal watershed regions, with a couple of foci that demonstrate acute diffusion restriction with corresponding low ADC values. And you can see this classic distribution of internal watershed. So this was a patient with a HBSS variant sickle cell disease, which was giving rise to this picture. Now, when we look at the vascular imaging, we can see that actually their right A1 was stenotic. They also have left M1 stenosis, better seen on the time of flight images on the axials. And also, as you can appreciate here, the left PCA was affected, so multifocal arteriopathy related to their sickle cell vasculopathy. On follow-up imaging, you can see this patient's had some intervention, so they've had an ECIC bypass, and the affected side demonstrates cortical volume loss as well as areas of white matter ischemia and cortical stroke. Again, when you look at the reconstructed MRA, you can see that there has been extreme loss of opacification and further progressive vasculopathy affecting the entire anterior and posterior circulation on the left. So sickle cell disease can cause both ischemic and hemorrhagic presentations of stroke. The risk of ischemic stroke is increased to 400 times by having sickle cell arteriopathy. Large vessel vasculopathy is the type that is seen most commonly, where it is occlusive, and children present with a Moyamoya-like syndrome in 12 to 23% of cases. In the past, there was a great emphasis on sort of exchange transfusion to reduce the quantities of HBS within the bloodstream, reducing the relative risk of the first stroke. And now we know that these children can be cured completely by actually performing bone marrow transplants, although that comes with its own risks. Moving on to case 2. So this is a 10-year-old with tingling and absent seizure-like episodes, no associated syndrome at the time of presentation. And as you can see here, they have quite classical features of Moyamoya arteriopathy. So you can see the flare IV sign where there is lack of CSF signal suppression on the flare sequences. You can also see on both the reconstructed images as well as the axial slabs that there is a progressive occlusion of the ICA and its distal branches, and you can see these collaterals which are formed, giving this puff of smoke appearance. Now, the name puff of smoke has its origins in the Japanese language, which essentially means a cloud-like appearance. And the pathophysiology of Moyamoya disease, or Moyamoya arteriopathy, which this is that there is a reduction of blood flow into the brain due to this progressive arteriopathy, and there develops a compensatory angiogenetic response which produces further intracerebral network of small caliber collaterals. And now the primary form of the disease, as we know it, is originating from Eastern Asia. You can pin it back to the ring finger 213 or RNF213 susceptibility gene, which is typical for the primary form of Moyamoya. And this gene is relevant because it's involved in the proliferation and inflammatory signaling of endothelial cells, vascular stability and pruning, as well as vascular apoptosis. So this is a very interesting study actually performed in Switzerland by the University of Basel, which looks at the genetic landscape and the clinical implication of a pediatric Moyamoya arteriopathy. And they look at an international cohort, and they try and subtype each type of Moyamoya arteriopathy as they find it. So they found that 19% of the population had the RNF2 and 3 susceptibility gene. They found that 43% of their population were non-RNF Moyamoya disease, and the rest, or as we know them as Moyamoya syndrome, were caused by things such as NF1, trisomy 21, spherocytosis, and other rare diagnoses. Now, what I found very interesting as a radiologist was the genotype-phenotype correlation for the angiographic findings. So what was found in the 88 patients that they saw, that when a child has Moyamoya arteriopathy, the ACA and the MCA territories are the ones that are most commonly affected. And actually, when there is an RNF213 variant, the involvement of the PCAs is significantly higher. So they tend to have bilateral PCA involvement, and they also tend to have a much more younger onset of disease. So they have greater posterior circulation involvement and higher stroke rates. And the reason to note this is actually by alerting the clinician to posterior circulation involvement early on. This has implications in starting treatment earlier, such as planning an EC-IC bypass earlier, and also promoting early screening of siblings. Moving on to our next case, this is a 5-year-old who presented with right-sided hemiparesis. Now, they had an infection of varicella zoster about 6 months ago, and actually in this case, the clinicians confirmed VZV-IgG within the CSF. But as you can see here, this is actually a follow-up study where there is a clear arteriopathy of the left MCA, and you can see that there is corresponding cortical volume loss within the left MCA territory, which is a sequelae of an old stroke. This is a companion case where there was a slightly vague presentation history of fever, headache, new onset dizziness, diplopia, and also a right-sided third nerve palsy. And this was an 18-month-old. What we found really interesting actually was that there were 2 areas of cerebral arteriopathy. So you could see that there was some stenosis in the left distalized CA and proximal MCA, but also the P2 segment of the right-sided posterior cerebral artery. And what you can see on this T1 spin echo actually is that actually there is post-contrast enhancement of that proximal segment of the left M1. In addition to this, we can see that there is an acute stroke involving the caudate head, the putamen, and also parts of the plic, which may actually be related to Wallerian degeneration, or the plic part of it specifically might be related to the Wallerian degeneration. Again, this is interesting because it is a form of transient cerebral arteriopathy, or previously known as transient cerebral arteriopathy, currently known as focal cerebral arteriopathy of the inflammatory subtype. It's a presumed prior infectious phenomenon, and you essentially get progressive arteriopathy for about 6 months, with hopefully stabilization or improvement after that point. So this is another Swiss study which was performed in 2023, which looks specifically at the involvement of the posterior circulation within focal cerebral arteriopathy of the inflammatory subtype. Now, the reason why this is important, the reason why I'm showing you this, is because traditionally FCAI is a disease which involves the anterior circulation predominantly, and that is how a lot of stroke clinicians as well as a lot of radiologists know it. But what is really important to know is that it can involve the posterior circulation, and to not be deterred from calling something an FCAI just because there is involvement of the posterior circulation, either in isolation or in combination with anterior circulation involvement. And this study demonstrates exactly that. So out of 36 children, 24 children had involvement of the anterior circulation, which is the most common type. 7 children had involvement of the posterior circulation, and 5 of those were overlapping between anterior and posterior circulation. This tells us that when there is posterior circulation involvement, which is less often than anterior, when it is involved, it will involve the anterior circulation in most cases. This is just important to know because there are differing clinical presentations. Upon involvement of the posterior circulation, the patient can experience different types of symptoms such as headaches and eye signs, which our patient actually had. So how does this happen, and how does the virus end up getting into the vessel wall of the posterior circulation? So we know that it's been hypothesized for a long time that the VZV lives in the trigeminal ganglia, and upon reactivation the viral capsid might migrate through axonal retrograde transport to the vessel wall of the proximal segments of the circle of Willis. Here it replicates and it induces a local inflammatory response. What has also been shown from experimental studies in monkeys is that intracerebral arteries receive afferent fibers from both trigeminal as well as the superior cervical ganglia, which can both harbour latent varicella infection. So not only does this viral capsid migrate to the carotid T-junction, but to a lesser extent to the PCA and also the rostral basilar artery as well as the superior cerebellar artery. So what we've learned is that infection clearly has an important role in the pathogenesis of FCAI. Several studies have found an association with varicella zoster virus in particular, which could be an infectious, parainfectious phenomenon leading to inflammation of the vessel walls and secondary arteriopathy. Now, the VIPS trial in particular has shown the vascular effects of infection in pediatric stroke, and there has been a clearly documented increased risk of childhood stroke, childhood acute ischemic stroke in particular, 1 week after infection, particularly with varicella zoster virus, and particularly in poorly vaccinated children. A significant proportion of these children can go on to develop an arteriopathy, and in those children who develop an arteriopathy, there is a 5-fold increase in stroke recurrence. So what is our learning point about arteriopathies? That A, they cause more than 50% of strokes, that they can be progressive, either inflammatory subtype or non-inflammatory subtype. So inflammatory being the FCAIs and FCADs that we see secondary to inflammation, potentially post-infection. The non-inflammatory subtypes being the Moyamoya disease, and also that arteriopathies can be non-progressive. Let's move on to our next case. This is a 5-year-old who had episodes of hemiparesis and MR imaging as demonstrated above. Now, this is a bit of an Aunt Minnie, and essentially it's very, very classic to have bilateral internal watershed territory infarcts or areas of chronic damage. You can also see that there is some classic straightening of these vessels. And this is a classic case of an actor 2 vasculopathy, which is an autosomal dominant multi-system disorder affecting smooth muscle function in particular, and is associated with progressive pediatric vasculopathies. There are other genetic vasculopathies which we will touch upon. I find ADA2 deficiency very interesting. So this is caused by mutations in CRC1. So that's a loss of function mutation, and this can lead to ADA2 deficiency. The reason why it's so interesting radiologically is that it can lead to sort of overlapping clinical manifestations with polyarteritis nodosa. So it can give this characteristic inflammatory skin lesion, and within the brain, patients can present with recurrent lacuna strokes, confusing and overlapping the diagnosis with PAN clinically. Another type of genetic arteriopathy, which is very interesting, is ELN. So ELN encodes for elastin, and abnormal elastin causes smooth muscle proliferation. Can have a slightly different course to Moyamoya disease with a poorer response to the revascularization process. You can also have MYH11 mutations, which can develop a similar radiological appearance to Moyamoya with formations of basal collaterals later down the line. Some other genetic conditions which are associated with vasculopathies include NF1, COL4A1 and COL4A2, NOTCH3, and ABCC6. Other causes of cerebral arteriopathies, in addition to FCAI and FCAD and Moyamoya disease and syndrome, as well as the genetic arteriopathies that we touched upon, are fibromuscular dysplasia, where you get this non-inflammatory arteriopathy that can affect carotid and renal arteries, and the underlying pathology can involve the intima, media, tunica, or the adventitia. There's thinning of the vascular wall and a classic string of beads appearance. You can also have primary CNS angiitis or vasculitis, where classically we see hemorrhage and infarcts with eccentric vessel wall enhancement, which can also be seen in other systemic conditions. Mineralizing angiopathy is actually a very interesting basal ganglia stroke etiology, which is seen in infants, and it's particularly seen after sort of repeated head trauma, which can be quite a confusing diagnosis. Essentially, there is thrombosis, which is precipitated by stresses across the mineralized artery, leading to a stroke. After arteriopathy, as we touched upon, cardiac causes are an important risk factor and account for approximately 10 to 30% of cases of acute ischemic stroke. Cardioembolic strokes in general, just to speak about them a bit, they tend to be anterior more than posterior, affect the left side of the circulation more than right side due to the direct route from the heart. And some studies have shown that posterior circulations tend to be associated with a slightly older age and a male preponderance. I just thought I'd show this case from Gosh, which has also been published, as we speak about posterior circulation strokes. This is actually a child who had a posterior circulation stroke in the context of hemolytic uremic syndrome. So HUS is obviously characterized by microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. And in this case, there was a left pica acute ischemic stroke. And when this case was looked into and a literature search was performed, we could only find about 6 or 7 cases which were reported where there had been a posterior circulation stroke in the context of HUS. And essentially there is postulated to be a sort of an underlying endothelial injury with inflammation in the cerebellar vessels caused by the E. coli 0157 infection. And it's important to sort of be aware that these upcoming imaging phenotypes are around. We classically associate HUS with the classic basal ganglia sort of injury, which is sort of metabolic toxic in its origin. But actually the endothelial and vascular dysfunction can lead to strokes, and posterior circulation strokes tend to crop up more than the anterior circulation strokes. Quickly moving on to hemorrhagic stroke, you can see here that there is quite a large posterior fossa bleed, which can also be seen on this sagittal T1 MR. And actually the root cause of this bleed was a left superior cerebellar artery AVM, which was diagnosed on DSA. So initially this child had a life-saving posterior fossa decompression performed by the neurosurgeons and ended up having gamma knife treatment to the left SCA with no residual seen presently. This is a companion case which demonstrates a large PL-AV fistula on the left side of the posterior fossa. On DSA, this was supplied by the left ICA. In this case, there is no hemorrhagic stroke as such, but these can very rapidly progress to hemorrhagic strokes if not addressed early on. Now, dural AVFs are also linked to cerebral venous sinus thromboses and can therefore cause venous infarct and hemorrhage in that way, as well as primarily through bleeding. This again was treated with gamma knife to complete resolution. So what are the different types of vascular malformations that we know of? There are AVMs, AVFs, which can be dural or PL, DSMs, which are dural sinus malformations, VGAMs, or abnormal connections of the median prosencephalic vein with the arterial system, cavernous malformations, and aneurysms. So AVMs are essentially abnormal connections between arteries and veins. You have an abnormal nidus of dysplastic vessels. If you have intranidal aneurysms or if there is venous stenosis, there is a higher risk of bleeding of the AVM. When you are born, the nidus or the intervening bed of vessels is not fully developed and they can potentially mimic AVFs. They have a bleed rate of about 2% a year and a rebleeding rate which is higher of about 23% a year. AVFs or dural PL fistulas can essentially present with secondary heart failure, and this one that we can see here was a 7-day-old who presented with exactly that. They had secondary heart failure. There's a particularly large fistula onto the right transverse sigmoid junction, which is fed here by principally a meningeal branch across the midline from the left. Essentially, this connection was then treated with coils and onyx, and the majority of that dural sinus malformation actually regressed in this way. Sometimes these can regress spontaneously, but that is very unlikely if the dural sinus malformations are this large. So VGAMs are essentially median prosencephalic vein and aberrant connection between that and the intracranial arteries. Again, can present with heart failure, macrocephaly, intracranial venous hypertension, and also hydrocephalus. Cavernous malformations tend to be slow flow. They're often associated with a DVA, have this popcorn-like appearance of blooming on the sweep. And also aneurysms, finally, are the most common cause of a non-traumatic subarachnoid hemorrhage in kids. So this is quite an interesting diagram, which is again taken from the same Nature article on childhood stroke, and essentially it shows us the various types of receptors that are involved in angiogenesis, vascular differentiation, migration, proliferation, and cell survival. And the receptors that you see in red here are targeted inherited loss of function mutations, and the yellow sort of signaling pathways down here that you see are somatic gain of function mutations. And essentially, vascular malformations can follow a two-hit genetic mechanism whereby an inherited genetic mutation and a somatic mutation potentially in the same gene, or two somatic mutations can cause lesion formation. So somatic mutations, for example, in the RAS MAP-PK pathway can cause sporadic brain AVMs. Several drugs have been approved for other indications, but have been shown to inhibit relevant pathways and reverse or even stabilize vascular malformations in animal models. And this hasn't really extended to the human population as such. There have been sort of isolated case report studies which have suggested that both AVMs and cavernous malformations that involve the mTOR signaling pathway can be inhibited by these mTOR inhibitors such as sirolimus, which can have positive effects in these children. However, large-scale studies on this are lacking, and this is potentially an area to look out for, as these could be potential adjuvant therapies to gamma knife or neurosurgery involving these large vascular malformations. Moving on to our case of a 3-month-old with a history of headaches, ear pain, and on initial presentation, no discharge. This kid then went to A&E on a background of vomiting for 24 hours and a GCS drop, and these were his CT findings. So there's clear right mastoid air cell opacification with some bony erosion, and also presence of an adjacent parenchyma with an enhancing sort of rim-like appearance, raising a possibility that this is an adjacent collection. Cerebral venous sinus thrombosis, the clinical course of this differs between neonates and the older children. So in the neonates, the etiologies differ, and in the age group that we're focusing on. So the incidence is about 0.7 per 100,000, occurs more commonly in neonates, and it's precipitated by systemic illness, also underlying coagulation disorders, chemotherapy with LS bargenase, trauma and head and neck infections. The incidence of sort of trauma-induced CVST increases with age. There's also a slight male preponderance, which may be related to underlying risk-taking behaviours. and it can present with features of headache and other signs of raised intracranial pressure. What's quite interesting to know is that the superficial system is more often involved than the deep venous system, and actually when the superficial system is involved, there's more of an increased chance of venous infarction. Moving on to our next case, this is a 13-year-old who presented with some right-sided visual symptoms which were sort of non-specific and vague, and essentially the child had a presenting complaint of headache combined with eye symptoms, and they had an MR scan which revealed that there was left parietal occipital swelling with associated cortical diffusion restriction. They were initially tentatively diagnosed as a stroke, represented a few months down the line, and the image here is their second presentation scan, which shows that the area of swelling has somehow migrated over to the right parietal occipital cortex, and the left side is sort of left atrophic. At this point, they also had an MRS, and I know this MRS is quite tiny on the screen, but you can see that there is a lactate inversion peak. And this is a child with the mitochondrial syndrome called MELAS, where essentially you get a migratory cortical stroke-like phenomenon, which is completely metabolic in its origin and classically appears to migrate. And what is quite interesting is that these episodes of metabolic decompensation are associated with intercurrent illness, which can often be red herrings, and can also lead to some developmental regression in sort of younger kids. This is a companion case of an 8-year-old who was admitted post bone marrow transplant for an underlying hematological condition, and essentially was experiencing some altered neurology with reducing GCS. The team were concerned of an underlying bleed, potentially an infarct. They also recorded some EEG epileptogenic activity, and the MRI revealed that there were bilateral regions of T2 flare hyperintensity, which were along the internal watershed or border zone region. Now, these areas also demonstrated some mild diffusion restriction, and this was a case of posterior reversible encephalopathy syndrome, which in itself is a misnomer, but is quite classically seen and associated with the drugs that are used around bone marrow transplant. And in addition to that, bone marrow transplant itself can be a predisposing risk factor for this. We must be aware of stroke mimics, which can present themselves as red herrings. So other stroke mimics include Todd's paresis, sort of post-epileptic activity, also meningoencephalitis, demyelination and tumours. And these must always be kept in mind, even if there is a sudden acute neurological decline. This is just a slide to show the summary of varying etiologies that can cause stroke, including hemorrhagic etiologies, dissection, focal cerebral arteriopathy, Moyamoya disease, and also thromboembolic clots from a cardiovascular source, as well as CVST. So these are the kind of etiologies that we've covered in today's lecture. So as we spoke about earlier in the talk, it is quite important to image cases of pediatric stroke within a certain time window, and actually one of the causes of delayed stroke diagnosis can be neuroimaging. And along that theme, whilst an MR is the gold standard for diagnosis, sometimes performing an MR out of hours can lead to a delayed diagnosis of the stroke, and in those instances a CT is preferred. It can be quick, it can be performed without sedation, but it unfortunately does have a lower sensitivity compared with MR. Now, MR imaging at a minimum should include DWI, SWI, and ideally an MRA brain and neck. There's also a phenomenon of a DWI and SWI mismatch, which is more popularized in the pediatric world, as it's an efficient way or an incidental way of effectively demonstrating a penumbra in the absence of perfusion imaging. So where there is a DWI and SWI mismatch, where a region of prominent veins on SWI are greater and are overlapping the surrounding area of diffusion restriction, this essentially reflects hypoperfusion that leads to increased oxygen extraction and increased deoxyhemoglobin within those veins and greater susceptibility effect, and can point towards a penumbra. A DWI flare mismatch is more commonly known, and essentially DWI PWI becomes positive within 30 minutes of an acute infarct, whereas a flare takes about 4 to 5 hours. So you can judge the acuity of the stroke through this method. This is a nice sort of algorithm which is taken for hyperacute and non-hyperacute strokes, and the option of performing a CT before an MR. Now we're going to briefly touch upon perfusion imaging. ASL, or arterial spin labeling, is a non-invasive technique which utilizes blood water protons as an endogenous tracer. It works on the principle of magnetically labeling arterial blood water molecules below an imaging slab, and these are then selectively inverted into the plane at which it is applied, like this. And once the protons within the blood are selectively inverted at the point of an imaging slab, you then have a post-labeling delay, following which downstream or in the brain upstream measurements are taken, and these resulting images are then compared to a control image without the inversion pulse. Subtraction between the labelled and the tagged images produces perfusion data, which essentially looks like this. And it's great because it doesn't require any IV access, there's no need for contrast or ionizing radiation, and you can perform perfusion images without having to cannulate the patient. So vessel wall imaging can be particularly useful in cases of vasculitis or focal cerebral arteriopathy, particularly of the inflammatory type, as most of the imaging modalities that we have to our avail only look at the lumen rather than the wall, and the wall can be involved in these etiologies. In our centre, we image at 3T because it offers better spatial resolution and improved signal-to-noise ratio, and we utilise the black blood imaging technique where signal from both blood and CSF is annulled, making vessel wall enhancement easy to spot. Now, just to end the talk, I just wanted to draw some parallels with adult stroke. So, the TIPS trial, which is spoken about here, it had a few goals, and these were to determine the safety and feasibility and the best dose of intravenous thrombolysis treatment for children with acute ischemic stroke. Unfortunately, due to poor enrolment, the trial was closed due to lack of accrual in the year 2013, and therefore thrombolysis is still not FDA approved for use in children, unlike in adults. So this is a study that was performed in France in 2022, which showed the effects of intravenous thrombolysis and or endovascular treatment, and tested their safety and efficacy in as potential revascularization strategies. So in this cohort of 68 children, 44 were treated with intravenous thrombolysis and or 40 were treated with endovascular thrombectomy, and they demonstrated favourable neurological outcome in 78% at the 1 year mark. The complication rates of revascularization treatments were low, and the main outcomes were not significantly different in children that had the endovascular treatment versus no endovascular treatment. So the findings of this cohort study were useful in suggesting that intravenous thrombolysis and or endovascular treatment may be safe in children with acute ischemic stroke. This was followed by some very recent data. So this Save Child's Pro study was published in December 2024, so this month of this year. And whilst we have tested the safety and efficacy of intravascular thrombolysis and endovascular thrombectomy in childhood stroke, this has not successfully been compared with best medical treatment. So this group performed a prospective international study which was led by the group in University of Basel in Switzerland. And to sum up the study, they had two arms. So one arm was for the patients undergoing endovascular thrombectomy. This recruited 117 patients, and the other arm was for best medical treatment. This involved 91. So what they did was that they measured the median pediatric NIHSS score on admission, which was higher for those who were selected for endovascular thrombectomy, and lower, which is the blue line, for those that were selected for best medical treatment. How they assessed the outcome was to look at the MRS scores. So just a reminder, the MRS score, so 0 is no symptoms, and then as the score increases, you have increasing levels of neurological disability. So they measured the difference in MRS score at 90 days from baseline, and they actually found that the difference in the median MRS score between baseline and 90 days was 1 in the endovascular thrombectomy group and was 2 in the best medical therapy group, so potentially better in the endovascular therapy group. Complication rates were similar, and then they specifically compared the primary outcome for patients with suspected focal cerebral arteriopathy. And in those subgroups, endovascular thrombectomy and best medical treatment showed no difference in the 90-day MRS scores. So what their conclusion was is that endovascular thrombectomy in general was associated with improved functional outcomes. This is quite a contentious topic in pediatric patients with large vessel or medium vessel occlusion compared with best medical treatment, where the cause of their stroke was focal cerebral arteriopathy. The outcomes were no different between the two groups. Again, these results need to be interpreted with caution, and future studies need to investigate whether the positive effect of endovascular thrombectomy is confined to more severely affected children. Thank you very much for your time. This is my email if you'd like to get in touch, and also my X handle.